Good evening, everyone. I welcome you all for today's webinar on Oncology Cancer Treatment Updates 2023. And with immense pleasure, I would like to invite Dr. Manish Sharma, who is Medical Oncologist, Unit Head, Action Cancer Hospital, Delhi, for the welcome and introductory note and to set the ball rolling. Over to you, sir.
Good evening, all, and thank you for being here on this Friday evening. And we will be talking today about lung cancer. What are the recent updates in the molecular diagnostics in lung cancer, and what are the various treatment aspects of the EGFR mutant lung cancer in particular. As we all know that the lung cancer is the most common cancer worldwide, and in India as well, this is the most common cancer nowadays, and the incidence is increasing. But the good thing about the lung cancer is that the maximum amount of research which we see in today's era is in lung cancer, and every now and then, in a month or 2 months or 3 months, we have now a new molecule or a new drug or a new protein targeted expression which is found by the help of the NGS, for which the targeted drugs are available. And hence, for the first talk, I am welcoming Dr. Anuradha. She is professor and scientist in charge in medical oncology, molecular biology, Tata Hospital, Mumbai. I welcome you, ma'am, here for this talk on molecular biology, what is new in 2023 in lung cancers. Dr. Anuradha?
Yeah, am I audible?
Yes, ma'am.
Yes, ma'am. Yeah, can you see my screen?
Yes, yes.
Yeah. Hello, everyone. Thank you for this wonderful opportunity, Dr. Manish Sharma. And I'm happy to share my experience and what are the latest biomarkers in the lung cancer as well. So to begin with, so what exactly are the biomarkers in the lung cancer, which will be reviewing in my next slides. However, among all the cancers, the biomarkers are well established in the lung cancer, as you all know. And today, the therapeutic decisions totally depends upon the biomarkers which are being detected. So first, how to proceed with this lung biopsy is a major concern in the lung cancer patients. Okay, so how to proceed with this lung biopsy? What are the principles of molecular and biomarker analysis, and how we can detect some driver actionable prognostic and the predictive biomarkers? My slide. Okay. I'm just going to the next slide. Yeah. So what are the potential barriers? What you can see this, how does the journey begins for the lung cancer biopsy? Here you can see when the test is ordered by the oncologist, the test, the patient goes to the interventional radiologist with the for the CT guided biopsy and to get the core biopsy as well. If at all we need to also go to the pulmonologist to get the tissue, if depending upon the size and site, actually all these biopsies, different types of biopsies are decided. So there are some, if there is an inaccessible site, like if the patient in PS3 or 4, patient will not be willing to do the biopsy. However, but initially we definitely have to look for the tissue biopsy. The surgeons may do the excision for the lymph node, which is very rare. And then the journey is taken to the pathologist who does the diagnosis for the histology testing, and then it is advised for the molecular diagnostic. If there is an in-house facility of the molecular diagnostic testing, it's well and good because it reduces the turnaround time. But however, if the samples are to be outsourced, then we need to look for the logistic partner of the outsourced lab. And after this, they do the molecular diagnostic, either because nowadays only the NGS panel is referred. The single gene testing is not affordable because the tissue is an issue. So once so either you can liquid biopsy testing also can be an alternative if there are potential barriers in this tissue biopsy, which also reduces the turnaround time. And liquid biopsy is also been advised by is been recommended by the as per the ASCO guideline. As you all can see, the tissue is an issue, so the pathologist has to use it very judiciously, and we need to manage the course. The different types of course for the morphology, for the IHC, for the fish, and for the NGS testing. So as I said, we need to economize on the use of tissue. So each core of tissue can be blocked separately. There can be initial diagnosis completed using 4 sections. You also can rely on morphology and limited IHC. But however, we need to keep in mind that we have to go for the reflex testing like IHC or FISH based for the specific biomarkers. So appropriately, number of tissue sections are cut first in time. No repeated trimming of block and wastage of tissue should be happening, and we need to control the turnaround time. As I mentioned, there is a mature data now coming up because of the large driver actionable mutations being done based on the next generation sequencing platform. And you can see you can very well differentiate between the adenocarcinoma and the squamous cell carcinoma if there is a huge profiling. Like you can see predominantly the EGFR sensitizing mutations are seen in the adeno than squamous, where you can see more of EGFR amplification in the squamous cell carcinoma. So there is a lot of prevalence of oncogenic driver alteration in the lung adenocarcinoma. As you all know that there is a different of frequency, overall frequency rate differs between the white, Asian and the black. You can see over here, the KRAS is predominantly higher in the white as compared to the Asian and black. But however, you can see in the ALK fusions, you get to see almost similar, but still you get to see the ALK fusion more in the black rather than in the Asian and the white. Then to ROS1, there is also it is predominantly high in the black as compared to the white and the Asian. So definitely there is a geographical difference in the various driver actionable mutations within the white, Asian and the black. So as these are some of the rare mutations. However, you can see almost EGFR mutation and KRAS, you can see is more in the black rather than in the white. So other than these mutations, common canonical mutations, we also get to see the rare mutations, which comprises around of 34%. But however, there is no definite, as of today, there is no unified definitions of a rare molecular subtype of lung cancer exists. Because in Europe and Asian, the percentage, less than 6% within the 1 lakh is considered to be a rare mutation. However, in US, less than 15% within, as per the compared to the Europe and Asia are as considered as the rare mutation. So it differs with the geographical variations of the rare mutations. So the survival rate of the patient with drivers in lung cancer mutation consortium, as you can see over here, targeted versus no targeted therapy. More and more targeted therapies are coming up, not only for the canonical mutations, but also for the rare mutations, which you will be able to see in the next slide. As you can see, as compared to the no targeted therapy, the survival rate is definitely higher in the targeted therapy. And so the LCMC demonstrated that the best outcomes are seen in patients with identified drivers placed on the targeted therapy. So you all can see over here, the median survival rate is around 3 to 5 years. So potential applications, as I mentioned earlier, that there are potential application in uncommon mutation beyond EGFR and ALK is around 34%, and definitely there are no definite unified definition for the rare mutations as of today. It totally depends upon the different platform detection of on the different platforms also, which rare mutations are getting detected. So as you can see, the ROS1 fusion, RET fusion, BRAF, V600, MET splice, MET amplification, ERBB2, and ERBB2 mutation are considered to be as the rare mutation. So in all total, we get to see around 14.5% of rare mutations. So what is the majority of the these common and uncommon driver mutation targetable with an FDA-approved drug or on a clinical trial? As you can see, EGFR sensitizing mutation, which was the first marker to be identified for the treatment, was the gefitinib, erlotinib, afatinib. And nowadays, osimertinib is also considered as the first-line therapy treatment for the EGFR sensitizing mutations. Other than EGFR, you get to see in ALK fusions, you get to see crizotinib, alectinib, and so on. And definitely with the same, most of the goes with the RET and ROS fusions as well, crizotinib and entrectinib, which are the common mutations for the driver actionable therapies for the MET exon 14, that is capmatinib and tepotinib. Other than that, interestingly, EGFR exon 20 insertions is becoming more and more mature data, and there is a specialized treatment for this with the exon 20 insertion. Like you can see amivantanib and mobocertinib. However, many drugs which are not available in India, most of them, but Tata Hospital get to see that they're available on the compassionate basis. You also get to see the RET fusions and NTRK fusion targeted therapy for these rare mutations as well. So there is definitely an evolution of therapy in lung cancer, as you all saw in the previous slides. So you differentiate between predominantly non-small carcinoma is predominantly high as compared to SCLC, and there are different histologic breakdown in the different types of lung cancer: squamous cell, non-squamous cell, large cell, small cell adenocarcinomas, and so on. And after this, there is a evolution of molecular pathology, identifying the various driver actionable mutations. It's not only the mutations now, but we are also looking for the PDL1 expression level by doing IHC, and definitely the tumor mutation burden is also looked depending upon the mutation per ME. Yeah. So biomarker testing is in lung cancer is definitely a moving target. As you can see over different guidelines, so you can see in 2013, it was just the EGFR mutation, all gene fusions were started, but however, there was insufficient evidence to support NGS panel. But now with the 2018 onwards, you can see the various mature data coming up with the different panel, with the different biomarkers. So you need to add, not other than EGFR and ALK, you need to add BRAF, ERBB2, MET, RET if you are doing a large panel. And then, of course, you can, as if tissue is an issue, as I mentioned earlier, you can do the liquid biopsy, bigger panel on the liquid biopsy, cell-free DNA as well. So as per the ASCO and NCCN guidelines, they extended the recommendation to include routine first-line BRAF mutation testing, which wasn't earlier. So this is the latest addition of this biomarker for the in the first-line testing of the lung cancer. So other than this, there is ROS1 gene rearrangement, which we need to look for. Then also we need to look for the NGS panels preferred over single gene test beyond first three mutations, beyond EGFR, ALK, and ROS. So, what are the minimum necessary non-squamous histology? PD-L1, IHC, EGFR, ALK, ROS, PDAM, and PD-L1 IHC. What are the recommendations? RET, MET exon 14, skipping HER2, KRAS, and NTRK fusion. So biomarker testing for all patients with advanced non-small cell is the real world issue and tough choices. So in 2019, ASCO educational book has come up, which which mentions about the biomarker testing for the patients with advanced NSCLC. Now, what are the EGFR mutations? Of course, this was the first EGFR mutations which started with the sensitizing mutations for the targeted therapy. So it's a very robust predictive marker which we can do it either by the single gene testing or by the NGS panel. So in Asian population, up to 60% of the incidences have been found, especially non-smokers of the and the females. Approximately 90% of all EGFR mutations consist of deletion in exon 19 or a single specific point mutation, especially the L858R in exon 21. So there are two FDA-approved tests like COBAS EGFR mutation test, and of course the Quagen TheraScreen EGFR RGQ PCR kit testing. So, but however, the single gene testing is not recommended nowadays in the lung cancer. So these tests are highly sensitive in samples with the tumor infiltration as low as 10 to 20%. So unfortunately, the resistant TKIs are inevitable. Other than this, you can look upon for the mechanism of resistance post first line, as it is well known that T790M mutation is the first line acquired resistant mutation, and for that osimertinib is the well targeted therapy which is come up. Other than this rare mutations, you all get to see the exon 20 mutations, and you can see there are various insertions and deletions which have been identified on the exon 20 mutation, and not only on the EGFR exon 20 insertions, but also we need to refer to oncogenic mutations. So there are several studies supports the use of plasma genotyping as a first line testing to detect the T790M mutation. So as you have seen that after the EGFR, it is the ALK gene rearrangement, which is very important. So more than 12 different variants of EML for ALK are seen, and non-EML for fusion genes also have been detected. So this impact of ALK variants is very much heterogeneous, and its response to the ALK inhibitors has not been fully elucidated. So 5 to 8% of the patients are seen with the EML for ALK positive markers. Of course, it is predominantly found in the young and the non-smoker patients. So there are various ALK inhibitors, as I mentioned earlier in the study, and I won't go much into the detail of this. So there are various methods of ALK detection. You can do it by the IHC or the FISH, which is by using a break apart probe. You can do it by the real-time PCR or NGS as a part of multi-gene assay. So this is the one that where you get to see the chromosomal translocations between the EML for ALK between the at the peak P arm of the chromosome 21. So there is a wild type which is a negative, where you get to see the two signal, and whenever there is a positive one, you can see there is a break apart probe which has been called as a positive. But of course, we need to do at least 200 cells to call it as a non-equivocal or identify the positive patient. So these are the IHC is done by the IHC, where you can see a strong positive test for the EML for ALK by doing the IHC method. So there are, however, IHC's advantages. It is faster, cheaper, standardization easier, more laboratories can do it, and it is also reliable as normal lung tissue do not express ALK. So, but however, the D543, that is Roche MAB, is used on the Ventana platform, which has been FDA approved as a companion diagnostic for the crizotinib. The superiority of the TKI over chemotherapy in the first line ALK advance was proven in 2014. Now, the third generation is the dorlatinib, who led to a 72% of improvement in the progression-free survival compared with the crizotinib in the first line treatment. Coming to the ROS1, which is another EML fusion gene, which is also as a receptor tyrosine kinase. It is seen in 1 to 2% of the NSLC, and you can see the translocation between the ROS1 and other. The commonest one is the translocation between the CD74 and the ROS1. However, the activation of these downstream pathways is the STAT3, PI3K, AKT, mTOR, and the RAS-MAP pathways. The sensitivity to ROS1 inhibitors are the crizotinib and entrectinib, which are FDA approved. So methods of detection for the ROS1, again, you can do it either by FISH or by NGS as a part of multigene assay. IHC, yes, D4, D6 is a very effective IHC methodology for the ROS1 detection, and you can use the SP384, which is the Ventana base and is recently recommended for the antibody testing. So all positive IHC cases must be confirmed by FISH analysis before starting on the targeted therapy, because IHC screening of the IHC is a very subjective issue. So as I won't go much, this is a case 3 where you can see the micropapillary pattern of the growth and how they were positive for the ROS1 testing. And you can see the strong and diffuse expression for this on the IC based method. So again, is the other than ALK ROS1, we get to see the BRAF, which is a downstream signaling pathways for the KRAS that activates the MAP kinase pathway. However, 1 to 3% of this BRAF mutations are positive, and as mentioned earlier, now BRAF testing is also considered to be as a first line testing on the NGS panel. So the preferred testing method are the PCR sequencing, that is single gene, or on the NGS platform. Dabrafenib and the trametinib has been are the approved FDA drug for the BRAF and the MEK as a MEK inhibitor. So these are the dabrafenib treatment plus trametinib in patients with previously treated BRAF metastatic non-small cell lung cancer. Again, you get to see the BRAF plus trametinib in patients with the untreated BRAF V600E. And so a lot of mature data is coming up for the treatment of the BRAF positive patient with the different types of imatinibs, different types of targeted therapies based on the presence of this BRAF mutations. So what are the recommended tests to be done? So you can see over here for the MET exon 14 skipping. So definitely MET exon 14 is another rare type of mutation. If there is a dysregulation of the MET pathway. So either there can be whole lot of exon skipping mutation of the exon 14, or there the MET exon 14 amplification. If it is there, then definitely they are the bad prognostic indicator. So however, as you can see over here, if there is a whole exon 14 skipping, then this exon 13 and exon 14 are fused, and we need to do at the mRNA transcript because they are at the mRNA transcript. So the DNA sequencing is not advisable, but we need to do the RNA sequencing to identify the MET exon 14 skipping. So these are the different IHC studies. When do we look for the possibility of the MET exon 14 skipping? As you can see over here, these are the various carcinosarcomatous differentiation. If it is there, then probably the MET exon 14 skipping is likely to be present. So this morphology pattern may warrant upfront for the MET gene testing. So what exactly is the MET exon 14 skipping? It is seen in 3 to 4% of the metastasis non-small cell cases. It can be associated with the MET amplifications, copy number variations, females in the elderly and the non-smokers. They are highly predictive of response to the MET inhibitors for the MET exon 14 skipping. The FDA approved the capmatinib and tepotinib for the metastatic NSCLC, whose tumors have a mutation of exon 14 skipping as detected by an FDA approved test. So either it can be an NGS. So the foundation one, CDX, is a DNA based method for the detection of met exon 14 skipping in the tumor tissue. So, but however, since it is at the mRNA level, we definitely need to do the RNA-based sequencing is preferred for the DNA-based engines. So it has the advantage of encompassing all casual genomic events that lead to the exon 14 skipping, and hence is being more sensitive. So RNA sequencing detects the fusion of exon 13 between exon 13 and 15. So in one study, approximately 60% of RNA positive results were false positive when they were done based on the DNA assays. Then comes this is how the exon, the schematic diagram, how the exon 14 skipping is kept, and you get to see the fusion between the exon 13 and exon 15. So whenever there is a dysregulation of this MET amplification as a mechanism of MET dysregulation is seen. So this MET amplification is regarded as a private driver gene and also one of the main mechanism of EGFR TKI resistance. So depending on the assay and positivity cut point is decided, the occurrence of de novo MET amplification is about 1 to 6% in the lung cancer. However, many studies are associated with the MET amplification with the shorter survival are seen today. So high amplification MET, that is CEP7 ratio more than 5, appears to be the strongest predictor of a true MET driver mutation, and that we need to look for the ratio that is 0.34% of lung adenocarcinoma are considered to be of very bad prognosis indicator. So the MET amplification is associated with poor survival, as I mentioned. So here definitely you can see with the on this Kaplan-Meier survival curve for the overall survival according to the MET amplification. So definitely it has shown a very bad prognostic indicator. With the less than 5 copies, you get to see a larger survival, but however, more than 5 copies, definitely the overall survival is very poor. So MET as a co-driver in NSLC. So MET amplification, I won't go again much into detail. Liquid biopsy might be a very important tool to use this situation to detect secondary mutation without repeat biopsy and discomfort. So now with the osimertinib as first line choice, the spectrum and association of MET mutation will remain to be seen in near future. After after the MET exon 14 skipping, now is the ERBB2, which is another rare mutation in the EGFR family receptor tyrosine kinase. It comprises to around 1 to 4% in the NSCLC tumors in non-smokers and the females. It can be detected by the PC or NGS, and majority of this HER2 mutations lies within the exon 20 in frame of insertions within the exon 20, and few cases show the point mutations as well. However, the early phase clinical trials suggest that patients with tumors harboring HER2 mutations are progressed on chemotherapy and may respond to the trastuzumab-based regimen. So trials demonstrated no benefit for the trastuzumab for the HER2 amplification. After this RET encodes the cell surface tyrosine kinase receptor, where it is the rearrangement is seen between the 1 to 2% of LADs, and of course it is found in the young and never smokers. So the testing methods, yes, you get to need to do only by the NGS, which is recommended, and not by the fish as well. So the FDA has approved selpercatinib and pralsetinib for the metastatic red fusion positive NSCLC, and it also encouraging results were seen in multi-cohort open label phase between the stage 1 and 2 of the study. So the red gene encodes a cell surface TKI receptor. It has after the red fusion, we get to see the NTRK fusion, which is it has a prevalence of up to 1%. So larotrectinib and the entrectinib are the two FDA approved drugs for the oral TKI inhibitors. So what are the recommended methods? Again, NGS is as a part of the multi-gene assay. You can either do by FISH, but however, the IHC is the best method where you can look for by looking for the clone EPR17341, and if you get to see the diffuse strong cytoplasmic staining, then it can be considered as a positive. However, the standalone tests are not cost effective and feasible. So the NGS method is recommended. The efficacy of lalotractinib has shown early phase in clinical trials, and you can see around there is a 75% of the response, which is a very short trial of the 12 patients. It has shown a very good response up to the 75%. So coming to this another rare mutation, NRG1, which is the fusions involving the neuroglial gene and are very rare. The recommended method is NGS. Data have suggested poor activity of chemotherapy and immunotherapy in NRG1 fusion cancers. So after this, there is a case series of 5 patients who received the afatinib therapy for NRG1 positive lung cancer, which demonstrated that 4 partial radiographic response in 5 patients, with 3 of these lasted over for the 18 months. So other targeted therapeutics against NRG1 fusions are in clinical trial development, and such as seribantumab trial is in progression. So after the NTRK and NRG1 comes the RAS family mutations. As you all know that RAS family are the very positive of this, are the very bad prognostic indicator. However, now with the sotorasib is an approved FDA approved drug for the KRAS G12C mutations. However, this drug is still not come into India, so the patients are being deprived. Though there are a lot of KRAS G12C patients, G12C mutations are detected in our patients. So the NGS, what are the methodologies, what are the NGS is preferred? Definitely, as you all see, we need to look for a whole spectrum of various rare mutations as well as the canonical mutations, and the tissue is an issue in lung cancer patients, so NGS is preferred over a single gene assay. So what are, however, there are certain, we need to follow the protocol. So at least there should be 20 to 30 nanogram of input for the DNA and RNA. There's a resource should be proficient, 1 experiment, 1 platform should be there. There are variant allele detection cutoff around 0.05%, hence it overcomes problem over lower tumor fraction. There are various tier 1, tier 2 and tier 3 alterations we need to look for, which are received as a targeted therapy. So tier 1 is where all the drugs are available and they're considered to be driver actionable mutations. Tier 3 still goes as a variant of unknown significance, and still the data gets matured, we cannot give the treatment to the patients. In the they have to be recruited in the clinical trials. So NGS also can use the plasma. There is FDA approved for the analytical, clinical validity and clinical utility. However, the NGS takes a turnaround time is very high, and it is not a cost-effective procedure as compared to the rest of the single gene testing. So what are the biomarkers for immunotherapy? Now, other than targeted therapies or the tyrosine kinase inhibitors, now the many immunotherapy markers are in progress. But however, as of today, no robust biomarker is in followed in the clinic in the therapy treatment. So what are the various pathways? As you can see over here, it is just not one. You need to look for the MSI. There are tumor mutation burden, and there are, of course, a PDL1 is the most marker which has been seen. So different ways of looking at the same problem for the IO therapy. However, the PDL1, as I mentioned, is a therapy-specific biomarker which has come up. So for the indications of immunotherapy, when should the patient go for the immunotherapy? If there are no targeted driver actionable mutation identified, and if the depending upon the PDL1 score, depending upon the MSI stability, and depending upon the tumor mutation burden mutation present, one can go for the immunotherapy. And if there are no options driver actionable identified, one can also go for the immunotherapy. It has been, there is a data mature data coming up. Whenever there is a KRAS positive, the immunotherapy works very well. Besides, if there is a PDL1 score low, with the low PDL1 score as well. So KRAS positive patients with no other targeted therapies available, one can very well go with the immunotherapy what has been suggested today. So So these are as per the NCCN guidelines, PD-L1 expression more than 50%. It can be, you can look for the adenocarcinoma, and for the squamous cell, the preferred treatment is pembrolizumab for the adenocarcinoma and as well as the squamous cell carcinoma. If the patient responds to the pembrolizumab, you can continue with the maintenance therapy. But however, in progression, we need to look for other than pembrolizumab as a systemic therapy as well. Similarly, it goes with the squamous. If the patient responds well with the pembrolizumab, the patient has to be carried with the same treatment. But with the progression, again, we need to look for the alternative therapy for the patient. So how is the PD-L1 marker done? It has been done on the IHC. The PD-L1 the method is the platform is the DACO autostener link 48, and the approved one is the IHC 22C3 assay, which is FDA as well as the CE mark approval. Also, there is a Ventana method, a Ventana platform, where we look for the antibody SP263. It is not, however, it is not FDA approved, but it is definitely a CE mark. So PD-L1 IHC testing is an established predictive biomarker for IO therapy in NSCLC, but not a very robust marker. Still, we need to have the best. So these are the various, I won't go much into the detailed clinical activity of the targeted therapies against rare mutations are available depending upon the copy number alterations in lung cancer as well. So EGFR exon 20 insertion, BRAF V600E, ERBB2, ERBB2 copy number increases. We have the various agents for as a treatment for that, and depending upon the patient population, we need to look whether the patient is being pre-treated or whether it's a very treatment is name, which are the treatments which will be very successful in treating the patient. There is a definitely results, good results with the objective response rate, median survival rate, progression-free survival rate, and the overall. I won't go into the detail, but this is the latest review article which has come up in Nature Reviews Clinical Oncology, that in the volume 20 of the April 23, very interesting article where they have illustrated that how different types of targeted therapy, rare mutations, targeted mutations, how the targeted therapies have come up, and how important it is to have these driver actionable mutations to be detected on the NGS platform. So as I mentioned, so for the MET exon 14 skipping, you have capmatinib, you have tepotinib, crizotinib, savolitinib, and amivantamab, depending upon the what type of treatment, and to decide whether it's a treatment name or pre-treated, and depending upon that, the overall survival rate, the progression-free survival rate has been available today. So this is another very important, interesting graph.
Dr. Anuradha?
Yeah.
I just request you to complete your talk in next 2-3 minutes, please.
Just 5 minutes, ma'am. So to conclude, this is my last slide. So lung cancer remains an archetypal example of a tumor type enriched for rare oncogenes, challenge over conceptions of mechanism of oncogenesis, and reshaped our approach to the molecular diagnosis. So the extensive role of biomarker testing in metastatic and advanced non-small adenocarcinoma is there. Available today, broad molecular testing and liquid biopsy have already made their place for biomarker assays, and there is a multidisciplinary communication is essential, that we need to have a molecular tumor board, frequent molecular tumor boards, to decide the therapy strategy for the patient. However, the quality information within the required time frame should be there, and the cost should be judicious if we are doing it on the NGS platform. So incumbent upon the pathologist to make the testing reliable by optimizing pre-analytical, analytical, and post-analytical steps are very essential. Thank you so much.
Thank you so much, Dr. Anuradha, for taking us through this presentation.
Yeah. Any questions? I'm happy to take questions.
Hello.
Yeah.
Thank you so much, Dr. Anuradha, for taking us through this presentation.
Yeah.
If there are any questions, then we can take few questions.
Yeah.
Dr. Anuradha, what is the status of liquid biopsy in lung cancer? So all the tests which we are able to do on the solid tumor are we able to do them on the liquid biopsies as well?
Yeah.
And all of them?
Yeah, we can have as you must have seen with the Guardian 360 and various companies have come up with a bigger panel. However, there are certain preconditions that depending upon the yield of the CF ctDNA and depending upon whether really they are pure ctDNA and there is not a contamination of the genomic DNA as well. So these are the things which we need to look for the actual liquid biopsy panel. But yes, if there is a very good yield, if we have a 50 nanogram of DNA, then we can go for a bigger panel on liquid biopsy, because definitely it is a representative for the spatial and heterogeneity of the tumor biopsy.
Thank you so much, Dr. Anuradha. I think we are short in time.
Yeah.
So I have one question,
Yeah.
Dr. Anuradha.
Yeah.
So what do you recommend? So now we have availability of liquid biopsy also. We have availability of tissue biopsy also. And how do you recommend sequencing of them? So whether to do both of them simultaneously or
so
how to sequence them?
So if the patient is affordable, I will advise to go for both profiling tissue as well as liquid biopsy. And if another thing is, if the tissue is not available, if there are certain, depending upon the site and size, or the patient is refusing to do the tissue biopsy, then very well we can go for the liquid biopsy. But yes, there is a good literature where they have shown a high concordance with the within the tumor tissue biopsy and the liquid biopsy as well.
Okay. And do you really see people doing NGS in small cell nowadays? So because now there are transcription or translation related small cells also which have been diagnosed recently. So are people doing NGS in small cell?
It has not been routinely done, but as the data, you can see there is mature data coming up for the small cell as well. But however, I can see that definitely if there is a patient in the adenocarcinoma and if you can see the P10 positive mutations, then definitely it indicates that in future there can be a transformation from small cell, large, adenocarcinoma to squamous cell, or from NSCLC to the small cell carcinoma. So I think it will be advisable to do on the small cell cell carcinomas as well.
Thank you, Dr. Anuradha.
Yeah, because many a times small cell are also involved with the germline mutations or with the acquired resistant mutations, which can go into the transformation. So if the patient is affordable, definitely I will say that we should go for the NGS panel in small cell lung cancer.
So with this, I would like to now invite Dr. Priyanshu. He is Senior Consultant Medical Oncology in Shelby Hospital and a very dear friend. He will be speaking on the overview of lung cancer. Dr. Priyanshu, over to you.
Thank you, sir. Thank you for the kind introduction. And without wasting any time, I'll be starting my talk. And are my slides visible?
Yes, Dr. Priyanshu.
Are they moving?
Yes.
Yeah, so perfect. So a very good evening to all of the listeners. And so I'll be giving a brief overview of lung cancer. What are the treatment option in the current era? So starting with the Globocan 2020 data, lung cancer is the fourth most common cancer among both sexes combined as of 2020 in India. And it is also the second most common cancer in males. When it comes to all overall incidence and mortality, it is number 4, both in incidence as well as mortality. So, lung cancer staging, it's very important. We have had some changes between the ages CC 7 and 8. And, the size, which was the primary tumor size between 5 to 7, which was earlier stage 2A has been moved to 3A, and similarly, with the T2, it has been moved to T3, as well as more than 7 centimeter has been moved from T3 to T4. So what are the investigative tools for staging? The most commonly taken the tests which are advised in our practice are bronchoscopy, a CT chest with contrast, and a whole body FDG PET CT. Along with, for medicinal staging, we can use a EBUS and plus minus an EUS, or if you have a medicinoscopy at your disposal, and MRI brain. So for what is the advantage of a PET CT over a contrast CT for staging in stage 3 NSCLC? So if you have a more than 10 mm lymph node along the short axis, it predicts of malignancy. CT alone has a limited role due to low sensitivity, that is 55%, and low specificity, that is 81%. But it may help in selecting appropriate procedures for tissue sampling by providing the images. Also, it is widely available, and it is less time consuming. The addition of PET to CT provides the overall sensitivity of 80 to 90% and specificity of 85 to 95%. So PET CT increases the sensitivity as well as the specificity, but it comes with additional cost. Now, N2 is an area which has always discussed when it comes to, stage 3 lung cancer. So what are the risk factors for finding an occult N2? It depends upon the size of the tumor, a higher SUV on PET CT, and the presence of central tumors. All these are risk factors for finding of occult N2. This has been shown in the study by Lee et al. So once we have diagnosed the primary and what are the medicinal staging options which we have, the less invasive one are EUS and EBUS plus biopsy, while the invasive one are medicinoscopy, which can be conventional, PAMLA, TEMLA, or through VATS. Now this is an important diagram. When we see the medicinal staging, there are 14 nodal stations which come under staging. And the first one is the supraclav, which are usually the N3 nodes. Then we have the superior medicinal nodes from station 2 to 4, the aortopulmonary, that is 5 and 6, the inferior medicinal, which are 7, so includes the subcarinal 7, 8, 9, and the hilar or the interlobal, which are usually the N1 nodes along the bronchus and its branches. These are from 11 to 14. So the most commonly used, the method which is easily available and less invasive is the EBUS and the EUS. And the clinical suspicion of N2 involvement remains high. Even after a negative EBUS, EUS, then we need a surgical staging with medicinoscope. So when is an invasive medicinal staging indicated? When they are centrally located tumors, irrespective of the size. And if the size is more than 3 centimeters, irrespective of the location, then there is extensive infiltration of the mediastinum with no evidence of extrathoracic disease, that is a heavy load of N1 disease. Bulky N2 on CT, then you don't need any invasive confirmation. If a discrete N2, yes, regardless of a PET CT result, you need a confirmation. The normal medicinal on CT, but positive on PET, then again you need you have to go an invasive medicinal staging. But if it is negative, then it is not required. Now this is a medicinal staging algorithm protocol. If we start with a PET CT finding, if it is a medicinal lymph nodes are positive, then we have to see whether they are bulky or non-bulky. If the mass is bulky, then no tissue confirmation is required. If it is non-bulky, then you go for a tissue confirmation through EBUS or EUS. And if it is positive, we go for a multimodality treatment. That is the chemo plus radiation. And if it is negative, then we go for a surgical staging of the medicinal lymph node. Now coming to again, if the PET-CT shows a negative mediastinal lymph node and it is a clinically N0 disease and the probability of unforeseen N2 is quite low, then we straight away go for radiation or surgery. But if these factors are not there and the probability of unforeseen N2 is high, then we go for again tissue confirmation by EBUS, EUS. And if they are positive, then we go for medicine for multimodality treatment. And if negative, then surgery or radiation. So this is one of the very good slides which I've come across in this presentation. So if we see what are the lymph nodes that cannot be sampled and which can be sampled by various techniques. So most commonly we use an EBUS and an EUS. So if we see the combination of EBUS plus EUN, EBUS plus EUS would be able to sample most of the lymph node except for 3A and 6. While the VAMBLA and TEMBLA are able to assess most of these lymph node except for station 11, while the cervical mediastinoscopy again or with an extended would be missing the station 3 and the lower one, that is 8, 9 and 10. So if we see again the sensitivity and specificity also of various techniques. So if we see here a combination of EBUS plus EUS has sensitivity of 91%, which matches those of mediastinoscopy. The best method probably would be a VATS, but it is an more invasive method. So again, it also depends upon which nodes you have to sample. Then again, as we said that EUS plus EBUS can miss station 6 and 3, while it able to sample most of the other lymph node stations. Now coming to the evolution of therapy in lung cancer initially, was considered a homogeneous disease, but these days we know that even with the same histology, there is a lot of variation with respect to mutations. And initially the traditional view was a small cell and non-small cell, and then non-small cell was again broken down into squamous, non-squamous, large cell, and adenocarcinoma. But again, now we have more than a dozen mutations and 7 approved indications for these mutations. Now after that, we also have classified according to the PD-L1 expression and tumor mutation burden. Now coming to the advances in management of non-small cell lung cancer, it has improved. The survival has improved drastically over the past few years. From even in the last 10 to 15 years, the lung cancer specific survival improved from 26% among men with NSCLC that was diagnosed in 2001 to 35% among those who were diagnosed in 2014. And even in the last 10 years or 9 years, I would say this has probably increased even more, at least in the Western countries. So if we see here, among men and women, both the incidence-based mortality has reduced by 6.3% in men and 5.9% in females. What are the advances in treatment of non-small cell early and late stage diseases? So 2011, crizotinib came into the picture in the ALK positive NSCLC. Then we had EGFR for EGFR allortinib, then geftinib, then ceritinib, then we had BRAF, dabrafenib, alectinib for ALK, and so on. Similarly, there's been the immunotherapy which came into the pictures from second line NSCLC, nivolumab to pembrolizumab in first line, to durvalumab, and then atezolizumab and durva in small cell, to nivo plus ipi with non-small cell lung cancers. So as I already discussed, that there are a lot of heterogeneity with respect to mutations, and even in the single subset of adenocarcinoma, there are a lot of mutations like KRAS, EGFR, ALK, ROS, RET, NTRK, HER2, BRAF, PIK3CA, HRAS, NRAS, AKT, MET exon 14, and MAP3K1 mutations. Out of these, 7 have FDA approval for targeted therapies. These include EGFR, ALK, ROS, BRAF, NTRK, MET, and RET. So apart from that, we now also have KRAS inhibitors, which have been approved. So what are the current guidelines? The current guidelines depend upon the pathological stage. So post-surgery, stage 1A observation is recommended, while for stage 1B to 2A, for high-risk patient, adjuvant chemotherapy is recommended, while there is no proven benefit of neoadjuvant chemotherapy. For stage 2B, adjuvant chemotherapy improves overall survival, while neoadjuvant chemotherapy is not indicated. Similarly, for stage 3A and 3B, neoadjuvant chemotherapy followed by chemoradiotherapy or adjuvant therapy after these are recommended. So now, what are the various surgical resection margins and how would they affect adjuvant treatment resection? So a negative margin is usually no residual tumor. Complete resection is R0 resection, while a positive microscopic margin is R1, and a positive macroscopic margin is R2. So the adjuvant therapy, usually the chemotherapy would be the same, but for early stage 1 and 2A, this resection is preferred, and if not feasible, then RT should be added. Similarly, for stage 2B, while for stage 3A and 3B, chemoradiotherapy is recommended if we have an R1, R2 margin, while for the complete resection, that is R0, the guidelines remain the same as discussed previously. So after initial treatment, more than half of the patient with resectable NSCLC experience recurrence within 5 years. So this is what needs to be improved. Also, after surgery and chemoradiotherapy, only about 40 to 50% of the patient remain cancer-free, while 50 to 60% recur. These recurrence can be local or distant. This is the latest meta-analysis which showed an overall survival benefit from post-operative cisplatin in early stage NSCLC. This was a pooled meta-analysis of 5 trials evaluating adjuvant cisplatin-based chemotherapy, which showed approximately 5% overall survival benefit at the end of 5 years, and 5.4 to be exact. And the most commonly used regimen here was cisplatin plus vinorelbine. So based on these guidelines, you have the ESMO guidelines which recommend adjuvant chemotherapy for stage 1B onwards with tumor diameter more than equal to 4 centimeters. Because stage 1B tumors were with more than 4 centimeters now have been classified as stage 2, and earlier they were stage 1B. So now adjuvant chemotherapy is now recommended for stage 2 onwards in all patients. So how well does neoadjuvant chemotherapy, that is induction chemotherapy, work? Probably about the same as adjuvant. This was a meta-analysis which showed that for stage 1B to stage 3, and neoadjuvant chemotherapy had a hazard ratio of 0.87, while adjuvant chemotherapy had a hazard ratio of 0.89. Now, apart from chemotherapy, are there other options for improving DFS and overall survival? So this answer was given by the ADAURA trial, adjuvant osimertinib. Patients who were completely resected stage 1B to stage 3A with EGFR mutated tumors were randomized to receive osimertinib versus placebo. And if we see, there was the hazard ratio was 0.20, 80% reduction in the risk of disease recurrence or death with osimertinib. With the introduction of EGFR TKI, DFS is improved from 44% in placebo to 90% in the EGFR TKI arm at 24 months. So this is an extremely good, DFS, especially when we have a dismal prognosis historically. So now it is now possible to further improve overall survival in completely resectable stage 1, 2, and 3 non-small cell lung cancer. So what about patients who do not have an EGFR mutations? Do we have something? Yes. Then this trial of adjuvant atezolizumab in a PD-L1 positive, that is PD-L1 more than 1% of the patient, showed an improved survival in adjuvant setting. The median DFS was prolonged significantly in this trial when compared to placebo. And we can see the disease-free survival at the end of 3 years is 60% versus 48.2% in the placebo arm. So this is approved in patients who have a PD-L1 more than 1%. Now coming to radiation, the techniques of radiation and the delivery of the radiation specifically to the tumor site has increased tremendously over the past few years, and advanced technologies have led to a safer treatment with reduced toxicity. So IMRT, that is intensity modulated radiation therapy, has been shown to improve survival for patients with stage 3 NSCLC and T3 to T4 tumors, and to reduce dose to heart with low rates of grade 3 pneumonitis, increasing dose to heart associated with higher risk of deaths in stage 3 lung cancers. So especially in left-sided tumors, IMRT is always preferred, and it is important to differentiate between stereotactic body radiation therapy, that is SBRT, versus conventionally fractionated EBRT, which for stage 3 lung cancers typically and IMRT. So SBRT is given, in a solitary lung lesion if we are, going for a definitive therapy. It is a high dose per fraction, typically 80 to 20 gray per fraction, 1 to 5 fractions, with 3D target localization, and it is used in early stage lung cancer, especially for patients who have poor lung, volume and a poor lung reserve, and patients who would not tolerate a surgery due to any medical condition. So for those patients, SBRT is an option for curative intent. So again, now we have 4D CT planning, which allows for margins around the tumor to be minimized, and image-guided radiation therapy, that is IGRT, which ensures accurate target coverage for every treatment while reducing margins needed to cover tumor. Adaptive radiation is creating a new radiation plan after target tumor volumes have reduced in size, and it allows for normal tissue sparing and smaller target volumes with lower doses to normal tissues, including lung, esophagus, and heart as the required end result. Now again, this is a trial published in Lancet in 2015, the RTOG-061 trial, which evaluated standard dose versus high dose chemoradiation therapy plus minus cetuximab in stage 3 or 3B non-small cell lung cancer. The 5-year survival was OS of 32% with high quality standard dose RT, and there was no role of RT dose escalation and no benefit of cetuximab addition. 60 gray was enough compared, and 74 gray was not tolerated, or neither it had a survival benefit. Now again, we have maintenance durvalumab, which we'll be discussing. So this is the Pacific trial, again a landmark trial, stage 3 non-small cell lung cancer, randomized to post definitive chemoradiation. Patient who did not progress on chemotherapy, that is, they either had a complete response, partial response, or stable disease, were randomized to receive a placebo versus durvalumab. And if we see significant overall survival and the DFS benefit was seen with this patient in this trial. If we see the survival at the end of 4 years was almost 50%, 49.7 versus 36.3, and with an estimated 6-year survival of 42.9 versus 33.4. So it demonstrated a 42.9% survival at 5 years, and compared to historical cohorts which have a survival of only 15 to 25%. So again, now targeted therapies are improving outcomes in advanced non-small lung cancer. Approximately 50% of the patient with advanced non-squamous NSCLC will have a driver mutation targetable with an FDA-approved agent or a clinical trial. So with chemotherapy, the median PFS is usually 5 to 7 months. And if we see with first generation TKI, it is usually 9 to 11 months. With the third generation, that is osimertinib, this PFS has increased to almost 19 months. Similarly, in the trials of ALK inhibitors, again, chemo probably 5 to 7 months, crizotinib around 11 months, that is the first generation TKI, and alectinib and now lorlatinib have achieved a PFS of almost 3 years, 35 months to be exact with alectinib. Now there are other emerging molecular targets we all know. For MET exon skipping, we have capmatinib, we have tepotinib, we have crizotinib. Similarly, for red mutations, we have pralsetinib and selpercatinib. NTRK, we have larotrectinib and tractinib. We have for HER2 mutation, adotrastuzumab emtansine, and now TDX is also coming with very good results. And similarly, we also have for KRAS, we have sotorasib. So a lot of studies are going on, and we have a lot of drugs emerging in this era of targeted therapy. So if you see the survival outcomes with targeted therapies, again, simple platinum-based chemotherapy between 4 to 6 or 8 months, and this probably a little bit better with non-squamous. Osimertinib increased to more than 3 years. Similarly, for ALK, probably it has crossed 5 years in the trials of lorlatinib. RET again, probably 1.5 years. NTRK, more than 2 years. ROS again, almost 1.5 years. BRAF, little bit worse, 17 months, and MET exon, more than 12 months. Coming to immunotherapy, that is immune checkpoint inhibitors, we know that it uses the body's own immune cells to fight cancers. We have a CTLA4 blockade and a PD1, PDL1 blockade. So if we see here, we all know the mechanism. The dendritic cell presents the antigen to the T cell, and this MHC class 2 antigen is presented to T cell receptor along with co-receptor, that is B7, which attach to CD28. So CTLA4 has a negative regulation for this activation of this T cell, and by blocking the CTLA4, this negative regulation is removed. So your own own immune cells actually act against the cancer cells. Similarly, there's a negative feedback by the PD1 and the PDL1 interaction, and the PDL1, which is found on the tumor cells, act as an inhibitory molecule for the T cell receptors, and by removal of this blockade, you activate the T cells, which lead to tumor cells killing. So this is how the approvals for immune checkpoint inhibitors was given over a period of time, starting in the era of second-line nivolumab and pembrolizumab to now coming to first line, even without a positivity of PDL1 along with chemotherapy. So this we have discussed. Now coming to immunotherapy in stage 4 lung cancers, pembrolizumab, we all know more than 50% PDL1 monotherapy versus chemotherapy improved the survival, and almost a third of the patients were alive at the end of 5 years in stage 4 lung cancers. Again, there are a lot of trials and a lot of studies going on of increasing the use of these inhibitors in a neoadjuvant setting. Adjuvant setting, we have approval of atezolizumab, but neoadjuvant setting, we don't have yet approval, but there are a lot of trials which are going on. So what is new? We now also have antibody drug conjugates coming up, extrapolated from breast cancers, and now have been tried in non-small cell lung cancer. Again, CAR T cell, definitely, promising option in lymphomas and, ALL, but these may be an option in future in solid tumors, especially lung cancers. So what are the key takeaways? The management landscape is fast changing in NSCLC. Newer therapies have a huge potential to improve survival, especially when detected in early stage. The overall survival has improved across various subtypes with molecular alterations. The ease of oral pills over infusion in case of targeted drugs is an added advantage. And the pulmonologist will play a huge role in early diagnosis, and it's crucial to involve them in non-small cell lung cancer tumor board. Thank you, and over to the organizers.
Thank you, Dr. Piachu. If there is any question, we can take a question or two. So, the next speaker for today's evening is Dr. Abhishek Yadav. He is medical oncologist at Yashoda Super Specialty Hospital, Kochapi, Ghaziabad, second on screen. He will be speaking on lung cancer management, what physician needs to know. Over to you, Dr. Abhishek.
A very good evening. Thank you, Dr. Manish, for having me on this platform, and thank you, organizers. Can you share the slides from my side?
You want to share your slides?
No. Please ask the organizers to share the slides from my side. Yeah, so today's topic that I'm going to discuss is lung cancer management, what physicians need to know. Next slide. So the topic of this discussion will be something which we will not go into very much details, but then this slide focuses on general physicians and the chest physicians, what basic knowledge we must all carry to guide the patient to a proper treatment. So the outline of these slides will be epidemiology of lung cancer, global and Indian, types of lung cancer and their survival, management and recent advances in NSCLC, resectable, unresectable and metastatic, current unmet needs and role of general clinical practitioners. Next slide. So most of the lung cancer treatment are costly and time consuming. So general practitioners can help in counseling and decision making and can take a huge part in cutting down the burden on oncologists. So role of general practitioners in lung cancer treatment. So high index of suspicions, early and prompt diagnosis, as lung cancer symptoms are non-specific and are common respiratory symptoms. Optimal reference to an oncologist. Brief the patient about the importance of various tests, taking care during complications, follow-up and recurrences. So we all see as medical oncologists or as an oncologist, we all see the patient gets tired up during the investigatory part or during the workup part. They feel that one after another investigations are going on. We are not reaching up to a conclusion. So it is very difficult to make them understand what genetic mutations are, what tyrosine kinase inhibitors are, what immunotherapy is. So this is a very tiring and long discussion. So if GCPs, that the general practitioners, can counsel the patient a little bit, then definitely the adherence to treatment will be much better. Next slide. So this is the Globocon data. The cancer today, the 5 most commonly diagnosed cancer types. So the lung cancer fares on the #1 spot in terms of incidence as well as the mortality. Next slide, please. So epidemiology of lung cancer in India. It is the 4th most common overall in incidence among cancer patients and 2nd most common in males. 3rd most common cause of cancer-related deaths in India. Most common cause of death in men with cancers. And the average age at diagnosis of lung cancer in India is around 54.6 years. Next slide, please. So very important is tumor classification. So lung cancer can be divided into a small cell lung cancer, which is more common in smokers, which accounts for around 15% of all the cases. And 85% are the non-small cell lung cancers, which comprise of squamous, large cell carcinoma, adenocarcinoma, and the rarer subtypes like alveolar cell carcinoma. So they comprise the majority. Next slide. Small cell lung carcinoma forms a 15% of subset, occurs almost exclusively in smokers, more prevalent in men than in women, So here it is written opposite, but this is more common in men than in women. Small size cells that spread or metastasize very fast. Lesions most commonly originate in central part of the chest. So the small cell carcinomas are central in origin. Very, very chemosensitive and radio sensitive, but over the time, the chances of relapse and recurrence are very high as they get resistant to the treatment quite frequently and quickly. Next slide. So NSCLC can be classified by histology or molecular subtype, squamous, others, and adenocarcinomas. So adenocarcinomas can have various mutations like ALK, HER2/neu, BRAF, PIK3CA, AKT1, MAP2K1, NRAS, ROS1, RET, KRAS, EGFR. Squamous cell carcinomas also can harbor some mutations, especially in non-smokers like FGFR1, EGFR, PIK3CA, EGFR. Next slide. So more than 50% of NSCLC adenocarcinomas have identifiable mutations that may drive treatment choices. So around 8% have an ALK rearrangement, 17% will have an EGFR mutation, 25% will have KRAS mutation, and ROS will form somewhere around 1 to 2%. And then, so the major three mutations are KRAS, EGFR, and ALK. Next slide, please. So unfortunately, majority of the patients are diagnosed in late stages. So if you see the resectable stages, only 25% patients present to us, 75% patients present either in stage 3 or stage 4. Especially in India, lesser number of patients, only 3.5% of patients are diagnosed in resectable stages. Next slide. So 5-year overall survival outcomes decrease with increasing stage in resectable NSCLC, as we can see in this graph, which fares from stage 1A1, 92% 5-year survival, to around 10% in stage 4A, in stage 4. And in 4B, it's almost 0%. Next slide. So management of non-small cell lung cancer requires multidisciplinary approach, which needs a pulmonologist, just because patients, first of all, go to a pulmonologist for their primary symptoms. Then the radiologist, the pathologists, the cardiothoracic surgeon, medical oncologist, unfortunately, come into play a little bit late, and the primary care physician. Next slide. So management of early stage 1, 2, 3A potentially resectable disease, stage 1 and 2, limited to one lung and not involving mediastinum or more distant sites, stage 3, when mediastinal lymph node involvement is detected. So goal in an early lung cancer is cure. Standard of, next slide. Standard of care treatment for resectable NSCLC is surgery with curative intent. So diagnosis, clinical staging, resectability assessment. If it is resectable, give a neoadjuvant chemotherapy followed by RT, or do a surgery directly followed by an adjuvant chemotherapy plus minus RT. If it is very, very early stage, even no adjuvant treatment might be required. If the cancer is unresectable, we will see what happens next. So molecular testing for EGFR mutations was not routinely performed on resected tumors until recently. So now we routinely perform EGFR mutation testing in almost every lung cancer patient. Next slide. So outcomes in early staged lung cancer need to be improved. Surgery is primary treatment. Adjuvant cisplatin-based chemotherapy is recommended for stage 2, 3A, and 1B patients. Results from various randomized RCTs like ANITA favors 5-year OS benefit with adjuvant chemotherapy. OS hazard ratio is 0.89 and DFS is 0.84. So what the problem is? The unmet need. The unmet need means the overall disease recurrences and deaths following surgery and adjuvant chemotherapy remain high across the disease stages. Next slide. So now this is a very important data which came up recently in last 2-3 years. Adjuvant osimertinib improves disease-free survival in resected EGFR mutant NSCLC. So primary population was stage 2 to 3A, and we can see the adjuvant osimertinib. There is a very clear separation in the graphs right from the beginning, which persisted over the follow-up of 48 months. This is the primary population, and in the overall population also, this separation of curves was very well maintained till 48 months. So median DFS was not recordable in osimertinib arm, whereas it was 19.6 months in the arm where no adjuvant treatment was given. Next slide. So adjuvant osimertinib, management of unresectable locally advanced NSCLC stage 3 when mediastinal lymph node involvement is detected. Previous slide, please. So when mediastinal lymph node involvement is detected, patients are classified as having stage 3 disease. And we need to do a mediastinal staging to prove it that this is a stage 3B or 3C. Next slide. So multidisciplinary team determines resectability and treatment path, which involves a pathologist, a radiation oncologist, medical oncologist, pulmonologist, and a thoracic surgeon. So definitive concurrent chemoradiation is the standard of care for stage 3 unresectable NSCLC. This can be done in a concurrent way or in the sequential way. Next slide. Survival rates remain low following concurrent CTRT in unresectable stage 3 NSCLC until recently. So very recently, we came across a concept of maintenance immunotherapy in these patients. So the patients who respond to chemoradiation, even partially, after 1 month of completion of CTRT, we put the patients on maintenance durvalumab, and we see that the survival rates have drastically improved by addition of durvalumab, which was almost 83% by 1 year, 66% by year 2, and 57% by year 3, which were previously 34%, 13%, and 9% at the end of 3 years. Next slide. So majority of lung cancer patients are diagnosed in stage 4. Treatment goals are extended survival. Previous slide. Extended survival, maintain and improve quality of life, relieve the severe and debilitating symptoms, and limit adverse events. Next slide. So stage 4 NSCLC, metastatic NLCLC, NET, NE11, M1 positive. Next slide. So diagnostic workups includes adequate histological subtyping. So having an adequate amount of tissue is very important. Molecular analysis is critical. All patients with adenocarcinoma component should have been tested with oncologic drivers. Next generation sequencing has come up in a big way in diagnosing even the rare mutations that these patients can harbor. Rebiopsy at the time of progression helps in determining resistance in EGFR mutated and ALK positive cases. So if the biopsy is not possible, liquid biopsy has come up in a long way. Next slide. So current metastatic NSCLC management driven by molecular testing, chemotherapy, targeted therapy, or checkpoint inhibitors, that is PD-L1 high. So targeted therapy and immunotherapy have changed that treatment paradigm and have become mainstay in the treatment of metastatic NSCLC with oncogenic drivers and high PD-L1 expression. So survival, which usually was 8 to 12 months, in FLORA study, as Dr. Priyanshu has already discussed, it reached up to 38.6 months. In Keynote 024 with pembrolizumab, 30 months. In PD-L1, more than 50%. Next slide. So EGFR mutations and the prevalence. So EGFR mutations are correct deletions, insertions, or point mutations. So they are oncogenic drivers detected in approximately 50% of Asian and 22% of Caucasian patients. For India, EGFR positivity rate is around 25-30%. Most commonly found EGFR mutations are exon 19 deletions and L858R mutations in exon 21. And other than these mutations, they are classified as uncommon mutations. Next slide. So targeting of these EGFR mutations has become very important because this is the most common mutation that we encounter in NSCLC. So first of all, they were the first line drugs, gefitinib and erlotinib. Then came the second line drugs, afatinib and decomitinib. And then the third line drug, which is osimertinib, which is even active against the T790M mutation. Next slide. So as we can see, the efficacy of EGFR TKIs for advanced EGFR mutant in SCLC kept on increasing as we have moved from first line to the third line therapies, with a very drastic jump between the second line and third line. So osimertinib clearly proved to be much more beneficial than afatinib, and definitely much more than the decomitinib. Next slide. Next slide. So osimertinib is the preferred drug. That is the category 1 recommendation in a metastatic EGFR mutant NSCLC. Other drugs that can be given, they also are counted in category 1, but then they are not preferred. They are erlotinib, afatinib, gefitinib, decomitinib, and erlotinib plus ramucirumab. Next slide. So advanced NSCLC, when they have no driver mutations, immunotherapy comes up in a big way. So if PD-L1 expression in the tumor is more than 50%, you can take up the patient for single line pembrolizumab. If it is from 1 to 49%, then a combination of immunotherapy with chemotherapy. The chemotherapy arm is usually pemetrexate and platinum or paclicarb plus bevacizumab plus atezolizumab. Next slide. So summary of stage 4 NSCLC is, over a period of less than 10 years, treatment of metastatic lung cancer has evolved to the point that has previously universally fatal disease now has become potential of being considered a chronic illness for a minority of patients. So despite these advances, most patients with metastatic lung cancer still die from their cancer within 2 to 3 years of diagnosis. Next slide. Summary overall and unmet medical need. The overall 5-year survival in SCLC is between 10 to 15%, primarily because majority of the patients present with either locally advanced or distant metastatic disease. Very few in India are diagnosed in early stages. So that is the most unfortunate part. Also, as high as 30 to 60% of SCLC patients undergoing surgery eventually develop metastatic disease. So we need to improve the neoadjuvant and adjuvant treatment options in early stages in order to improve the outcomes. So adjuvant osimertinib is definitely going to prove to be highly effective and practice-changing treatment for patients with stage 1B, 2, 3A EGFR mutant NSCLC after a complete tumor resection. Next slide. Improving cancer literacy and awareness is again very important. Increasing access to most of the innovative medicines. Cost plays a very important factor in the Indian setting. Evolving how we think about patient support to reflect increased survivorship in lung cancer. Enabling early diagnosis of lung cancer. That is, screening is very important. Unfortunately, in India, the concept of screening lags behind and we pay a very less important to this thing. Next slide. So there is a hope for a future with less lung cancer. With this, I conclude. Thank you all once again for listening. Thank you so much.
Thank you, Dr. Abhishek, for such a nice presentation. So how do you approach your patients with stage 4 NSCLC? So do you do the testing as a single gene test, or you have started doing NGS for all your patients?
Dr. Manish, now we have almost every lab doing a 12 gene or a 20 gene pulmonary pulmo dedicated NGS. So now I have resorted to, if the patient has a very high disease burden, I start with the chemotherapy early on, and I try to send the NGS, the lung directed NGS of 12 to 20 gene panel early on.
Thank you so much, Dr. Abhishek.
Can I ask one question here? The same question which was asked me. So, Dr. Ashish, what is your practice? Do you advise small cell lung cancer carcinoma patient for the NGS profiling?
No, till not now. Till now, not. I don't do that.
Okay.
At least not in the first line or second line setting. Later on, maybe in the next lines, when I am burnt out with the options, I might go for NGS.
Thank you.
Thank you.
Thank you so much, Dr. Abhishek. So the next session, I will be speaking on the real world data on osimertinib, and the last session would be taken by Dr. Praveen Jain. So can you share my screen, Yashika?
Sure, sir. 1 second.
I'm not able to share my screen.
Sir, do you want me to share the screen or are you sharing?
No, I will share the screen.
Okay, now you can share.
My screen is visible.
Yes, sir, it's visible.
Hello.
Yes, sir, it's visible.
Okay. So I'll be speaking on the real world data on osimertinib. And firstly, I will be discussing the trial of osimertinib in EGFR mutant lung cancers. And then this was the FLORA trial, which was a practice-changing trial. The drug here was osimertinib, and the median progression-free survival was 18.9 months versus 10.2 months. So I'll be discussing first FLORA trial, followed by the real-world data. This is a practice-changing trial, and as you can see here, the overall survival, median overall survival was 38.6 months versus 31.8 months in the FLORA trial in the experimental arm. So this is the trial schema. All the patients, they were stage 4, advanced NSCLC, who had EGFR mutation, either exon 19 deletion or L858R mutation, with no prior systemic anti-cancer treatment. The patients, they were randomized into osimertinib versus gefitinib or erlotinib, which was the standard of care at that particular point in time. And the drugs, they were continued till progression. The primary endpoint was progression-free survival, and the secondary endpoint was overall survival. This is the baseline clinical characteristics, and more number of patients, they were from the Asian origin. We know that EGFR mutations, they are more in Asians. Non-smokers were more represented. And to note here that the CNS metastasis was permitted at the entry in these patients. So 19 patients, they were in the osimertinib arm who had CNS metastasis versus 23 patients who had CNS metastasis in the comparator EGFR TKI. More number of the patients, they had exon 19 deletion as compared to the L858R mutation. The PFS, as we can see here, was 16.9 months versus 10.2 months. In the experimental arm, it was more. And the hazard ratio was 0.46. And not a single subgroup was there which did not benefit from the use of osimertinib as oral TKI. This is overall survival analysis, and as you can see here, the osimertinib, the median overall survival was 38.6 months versus 31.8 months with gefitinib or erlotinib. And at 3 years, the number of patients surviving were 54% versus 44% in the standard of care arm. And these were the conclusion. Conclusion was that the FLORA trial showed statistically significant, meaningful improvement in progression-free survival and overall survival. And the median OS was improved by 6.8 months, which is huge. And osimertinib is now the standard of care for the first line monotherapy in the EGFR mutant patients. After 3 years of the treatment, 28% patient in the osimertinib arm, and 9% patient in the comparator arm were on the first line study drug. So a great difference of almost 19% after 3 years. And as Dr. Abhishek also mentioned, the first line treatment is with osimertinib. This is a preferred drug, and all other are also category 1 indicated, but they are not more preferred as compared to the osimertinib. So coming on to the real world evidences, they are very, very important, because when the clinical trial is performed, it is performed in a very strict conditions, and the inclusion and exclusion criteria, they are very strict. But in the real world setting, the exclusion and inclusion criteria, they are not very strict, and we find many patients which were not included in the clinical trial setting getting benefit out of this drug, and in particular those patients who were more than 65 years of age. Then similarly, those patients who had brain metastasis, who had very poor PS, huge burden of disease, etc. So 3 trials I will be discussing. First is Flowert study, another is OSIFAC study, and third is Mykonos study. So this is first study, Flowert study. This is a brief introduction, and basically it introduces us about the FLORA trial, which has already been discussed. And it has been estimated that only 2 to 4% of the patients with cancer receive treatment within RCT, thus raising the issue of the representativeness. And hence, these kind of real world data, they are very, very important tool in the routine oncology practice. The clinical features here were 30% of the patients, they had brain metastasis, and median age was 68 in these patients. So the older age patients, they were represented, and you can see that the highest age group which was there was 88, and lowest age group was 30. Brain metastasis, 30% patient, they had brain metastasis at diagnosis. 94% patient, they had stage 4 disease at presentation. These were the inclusion and exclusion criteria. They were almost similar to the FLORA study. Age more than 18 years, histologically confirmed diagnosis, EGFR mutation 18 to 21, locally advanced stage 4, and eligible to receive first line treatment with third generation oral TKI. And these were the study endpoints: median time to treatment discontinuation, primary endpoint. Another primary endpoint was the treatment related adverse events and the rate of dose reduction or temporary or definite treatment interruption. The secondary endpoints were median overall survival, median progression-free survival, overall response rates, disease control rate, and diagnostic therapeutic pathway. So we will be discussing what happened to those patients who had progressed and how they were approached. What were the mechanism of resistance in these patients? Coming on to the effectiveness, the patients with poor PS, comorbidities, rare EGFR mutations, and active brain metastasis, they were included, which were actually excluded. Outcome was similar to the published data, and thus adding the consistency to the osimertinib efficacy. No difference in PFS, time to treatment discontinuation, overall survival was noted in elderly patients, patients with comorbidity, and less common EGFR mutations. And you can see the effectiveness. The author also came to the conclusion that the time to treatment discontinuation was more if patient did not have any symptom, but it was less if patient had symptoms at diagnosis. Similarly, those patients who had less than 3 metastatic site, they were having more treatment time discontinuation as compared to those patients who had more than or equal to 3 sites of metastasis. So the treatment outcome was poor if the patients they had brain metastasis, presence of symptoms, and at least 3 metastatic site at the diagnosis, suggesting that the tumor load was a negative prognostic factor in these patients. This you can see here with the hazard ratios, and it was statistically significant. Poor treatment outcomes for patients who had brain metastasis, presence of symptoms, or 3 metastatic site at diagnosis. These are the hazard ratios and the overall survival analysis. After median follow-up of 12.3 months, the median PFS was 18.9 months, which is similar to the FLORA study. And median overall survival was not reached at the time of data cutoff. No complete responses, partial responses were 73% and stable disease in 23% patients. So therapeutic pathway, 13 samples, that is 61% patient. So 44% patient had progressive disease. And out of them, the 13 samples were available for the molecular analysis for defining the mechanism of resistance. 4 patients had MET amplification. 1 patient had MET amplification plus EGFR amplification. 1 patient had EGFR amplification and 1 had HER2/neu amplification. Safety data almost similar, but there was a concern regarding venous thromboembolism. Apart from venous thromboembolism, diarrhea, pneumonitis, dry skin, paronychia were present. The venous thromboembolism was most common grade 3 side effect. So if you see, the 7.9% patient had grade 3 venous thromboembolism. No differences in the rate of venous thromboembolism was reported as per age, PS, comorbidity, and tumor load. No difference in survival outcome was observed according to age, comorbidity, and type of EGFR mutation. And osimertinib confirmed the effectiveness and safety in the real world scenario. So from this, the important thing which we came to know was that the venous thromboembolism was also a very, very important side effect, which was not as commonly reported in the FLORA trial initially. This is another study, osimertinib as first-line treatment option for advanced EGFR mutant lung cancer in real-world setting, OCFACT study. So this study investigated the difference in the efficacy with patient background and safety of the first-line osimertinib in the real-world scenario. Inclusion criteria, all the EGFR mutant NSCLC they were taken, and exclusion criteria, patient concurrently using anti-cancer therapy or undergoing thoracic radiotherapy, undergoing post-operative adjuvant chemotherapy, and receiving osimertinib as a second-line treatment. These were the baseline clinical characteristics. So many patients here had leptomeningeal disease also, symptomatic or asymptomatic, which were not represented in the FLORA trial. So here the leptomeningeal disease was also represented. Patients having pleural effusion, pericardial effusion, and liver metastasis at presentation. These were the clinical endpoints. Primary endpoint was progression-free survival. Secondary endpoint, overall survival, time to treatment failure, and the response rates. So PFS event occurred in 182 patients, and median PFS was 20.5 months in this real-world study. Other parameters significantly associated with PFS were male gender, malignant effusions, liver metastasis, and advanced unresectable cases. And with respect to PD-L1, you can see that as the PD-L1 status increased from 1% to 50%, the median PFS decreased from not reported to 11.1 months. So as PD-L1 increases, the expression increases, the disease does not respond very well to osimertinib. This is a similar slide which we have discussed. So these were the reasons for treatment discontinuation, and the most common reason for treatment discontinuation was 44% patient was disease progression, and in 25% patient it was pneumonitis. So this is very, very important thing. So 25% patient developing pneumonitis and refusing for the treatment. 16% patient, they had other adverse events like anorexia, skin disorder, cardiac failure, QT prolongation, fatigue, anemia, thrombocytopenia, and leukopenia. And 14.2% patient, they did not follow up. So if the pneumonitis has to develop, the median duration of onset is 56 days. For grade 3 hematological toxicity, it is 1 month. QT prolongation 230 days, and reduced ejection fraction, although not very common, just 1.5% patient, but it has to be checked. And the median duration for this is 3 to 4 months. Overall response rate was 76.2%, and disease control rate was 94.1%. PFS is better with osimertinib than conventional EGFR TKI, irrespective of PD-L1, although when PD-L1 increases, the duration of PFS decreases. Median time to treatment failure was 19.1 months. The median time from start of treatment to the onset of adverse event was 56 days, and pneumonitis of all the grades were reported in 12.8% patient, and grade 3 or higher pneumonitis in 4.5% patients. So this has to be remembered that the pneumonitis can occur in 4.5% patient, and 7.5% patient can have pulmonary thromboembolism. And the conclusion were PFS after first line osimertinib treatment in real world practice was favorable. The discontinuation rate due to adverse event was 18%, especially pneumonitis requires further investigation. This is another study, Mykonos study. This study reports the demographic and clinical characteristic of real world time to new treatment or discontinuation or death, and real world time to treatment discontinuation of patient with advanced EGFR mutant NSCLC who received first line treatment. And basically this is an ongoing study. The patient identification start date was April 1, 2018, and the interim analysis was done in June 30, 2020. And the last patient would be admitted in this study at June 30, 2023. So this is basically an ongoing study, and we present here the interim analysis of this real world study. Baseline clinical characteristics and demographic characteristics were summarized using descriptive study. Kaplan-Meier curve were used to generate estimates of time to new treatment or death and time to disease progression, real world time to disease progression. These were the clinical characteristics. And these were the type of EGFR mutations patient had. EGFR exon 19 deletion, 51% patient. L858R mutation, 33.7% patient. Both of them, 0.7%, both uncommon and common mutation, 4%, and uncommon mutation only 9.5% patient. So this is the treatment sequencing. First line osimertinib, and almost half of the patient, they remained on the treatment till the interim analysis. while 103 patient received second line treatment, 101 patient died, and 26 patient discontinued first line treatment. Those who received second line treatment, 58%, 18% patient received second line treatment, and this included EGFR monotherapy or chemotherapy or the combination chemotherapies plus immunotherapy. And this is real world time to new treatment or death. This treatment or death. The median follow-up time was 9.6 months, and the median real world time to new treatment or death was 17.9 months, which was almost similar to that of FLORA study. Outcome, 18.4% patient died, while 18.8% switched to second line treatment. Similarly, this is the multivariate analysis, which shows the variable that was significantly associated with this were stage at initial diagnosis of NSCLC, smoking status, comorbidity index more than equal to 3, EGFR mutation type. So L858R were less responsive as compared to the exon 19 deletion, and the number of site of metastasis more than equal to 4. If they were there, then the real world time to new next treatment or death was less. Similarly, RWTTD was 17.2 months. 18.4% patient died, 18.4% switched to second line treatment, 4.7% patient discontinued. And this was also significantly associated on the Cox regression analysis with the comorbidity index of more than 3, ECOG performance status of more than equal to 2, EGFR mutation type, and metastatic site, number of metastatic site more than equal to 4. So the study provides the real-world insight into the use of first-line osimertinib in patients with advanced EGFR mutant NSCLC based on first data cutoff analysis of US subpopulation. The interim real-world time to new treatment or death and real-world time to treatment discontinuation results support the effectiveness of osimertinib in this real-world population, and longer-term outcome will be evaluated in the final overall analysis. Thank you so much for your patient listening. If there are any questions, we can take a question or two.
So, hi Manish.
Hello, Dr. Praveen.
Hi. So, I want to ask one question. In fact, two questions. So, now with the such a good assistance program which is being given for osimertinib, so what percentage of your patients they are logistically feasible for osimertinib in first line? And second question is, so there is a vast difference as far as pulmonary thromboembolism or venous thromboembolism is concerned between the real world study and the phase 3 trial FLORA. So what is your observation about it?
So, Dr. Praveen, with the availability of such a good PAP, I think the initial percentage of my patient who would take osimertinib, only I am talking about the cash patients or those who had out of pocket expense, was not more than 10%, but now it has increased to 20 or 30% patients who can now afford this drug with the newer PAP. But almost all of the patients who are onto some kind of financial assistance from government panels or ESI or something like that, they would all receive this treatment, which is osimertinib. And secondly, I was also very shocked to see this real world study, which shows the higher evidence of pneumonitis and thromboembolism, which we did not see, and it was not never stressed upon in the FLORA trial. So this is really an eye opener for me. And also we can see that the few of the patient, 1.5% or 2% patient, they had in the floral trials. So these were really eye openers for me.
So another question, Dr. Manish. So, like, if a patient is logistically not feasible for osimertinib because of the finance, so what is going to be your like? How do you approach that patient? Do you really go ahead only with second generation or first generation TKI, or you add on chemotherapy to that? Because this is my concern, that I have done it only one of my patient where I had given gefitinib plus pemetrexed carboplatin. So have you ever used this approach in your patients?
So, Dr. Praveen, I have used this in my few of the patients, but I find that the combination is really very toxic. So, almost all of my patients, they had some grade 3 hematological toxicity with the use of the combination. Similarly, the liver toxicity was also very much as compared to the single agent treatment. So I have used it, but not. I do not prefer using it because of the toxicity.
Okay.
Dr. Praveen, so I would like Dr. Praveen to take on the next session, decoding treatment option for EGFR mutant NSCLC. He is senior consultant and head of department medical oncology at Akash Healthcare, Delhi. I would like to hand over the session to Dr. Praveen now.
Thank you. Thank you, organizers. Thank you, Dr. Manish, for giving me this opportunity. So I think Manish, you'll have to stop sharing your screen so that I'll be able to share my screen.
Now you can share, I think.
Yes, now I'll be able to share my screen. I hope my slides are visible
Yes.
and I'm audible too. So good evening, everyone. So I'm very sorry that my camera is not working. So I'll just carry on with the audio presentation. So my topic for today is decoding treatment options for EGFR mutated non-small cell lung cancer. So we've been listening to the options in EGFR mutated non-small cell lung cancer since the early evening. So, but when you have more availability of options, the more you are confused. So, which option to be used? So, there are different strategies. Like me and Manish were discussing about it. So, whether to go ahead with the first line osimertinib or we go ahead with the chemo TKI combination, or there are options like chemo VEGF targeted monoclonal antibody combination, or second generation, first generation, third generation TKI. So there are a lot of options which are available to us, and now whether to use third generation TKI or any of other strategies, we will see in the subsequent slides. So it's a big burden for us as far as the lung cancer is concerned. So, and it is in India among males. So it is one of the most common cancer, and it leads to most number of death in India as per the Globocan 2020 data. So it's a second most commonly diagnosed cancer and the leading cause of cancer death. And when we discuss about the EGFR mutated non-small cell lung cancer, the first line treatment, so there are a lot of factors which we consider while selecting the therapy for the patient. So first is the evidences, so the data. So what is going to be the progression-free survival? Whether it is more with third generation, first generation, second generation, we see overall survival also. So it's a best and reliable endpoint for the clinical trial. And for patient also, the thing which matters is that how long am I going to live. So the third is overall response rate, and these are particularly very important in those patients who have uh, 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 site at a disease at a critical site. or if the burden of the disease is too high, where we want to achieve responses at the earliest, and more number of patients should receive should achieve the responses. The fourth is the brain metastasis. So EGFR mutated non-small cell lung cancer, it is very notorious, and almost 40 to 50% of the patients with EGFR mutated non-small cell lung cancer will develop brain metastasis during the natural course of the disease, and almost 30% of these patients, so they have baseline metastasis to the brain. So it is very important to select our therapy on the basis of brain metastasis, because taking radiotherapy into the treatment of the patient, so it does have a good amount of response rate, but it on the other hand, it also has a lot of toxicity associated with it. So then the safety and toxicity of whatever agent we are choosing, then the quality of life, how it is going to be, because when we are giving oral TKI to a patient, it is very important that the quality of the life of the patient should be good. And in fact, in a stage 4 disease, so our first and foremost goal is to maintain the quality of life. And last but not the least, so what are the subsequent therapy options after progression on the first line? And one thing which is not mentioned over here, which is very, very important in our Indian context, is the affordability and accessibility. So taking the evidences into consideration, so let us see the progression-free survival. And we have first generation TKI, second generation TKI, third generation TKI, and first generation TKI. They have consistently shown a median progression-free survival of 9 to 10 months. If we see the second generation TKI, so they have shown a progression-free survival of 11 to 14 months. And third generation TKI, osimertinib in the FLORA, which was a phase 3 trial, so that showed a median progression-free survival of 18.9 months. So clearly we can see over here that the winner is osimertinib with the best progression-free survival. And if we see the inclusion criterias of these three trials, so second generation and the third generation trials. So the Lux Lung 7 was the second generation TKI, which was compared against the first generation TKI, and it showed a median progression-free survival of 11 months, and the hazard ratio was 0.73, and it was statistically significant. So, but the inclusion criteria showed that the stable brain metastases were included, which were 16, which were constituting 16% of the population. If we see the Archer 1050, so it was a phase 3 trial of dacomitinib, which was compared against gefitinib. So they had excluded all brain metastases. Even the treated brain metastases were excluded from this trial. And we can see over here that the median progression-free survival was 14.7 months, vis-a-vis 9.2 months with the gefitinib. So there are a lot of concerns regarding this. The curves were early on hugging each other, and at 6 months timeline, so the curves started to separate, and after that they remain separated. So if we see the FLORA trial, so which was the third generation osimertinib versus standard of care treatment, so which was the first generation TKI. So the graph separated immediately after the randomization, and we can see over here that the PFS was 18.9 months with the osimertinib, and the standard of care TKI were having 10.2 months of PFS, which was in line with the phase 3 trials of first generation TKI. And in this trial, stable brain metastasis patients were also included. So I know, so these are not head-to-head comparison of second generation versus third generation TKI. But when we do not have any head-on comparison and we have to select one agent over another, so sometimes we need to do cross-trial comparison, and we need to select out the best agent out of it. So coming to after PFS, coming to the overall response rate. So in Lux Lung 7 study, afatinib was having an overall response rate of 70%, and the disease control rate of 91%. And if we see in the gefitinib arm, so the overall response rate was 56% and the disease control rate was 87%. In dacomitinib Archer trial, so the overall response rate was 75% and the median duration of response was 14.8 months. So, but if we see Flora trial, so the overall response rates were the best with the osimertinib. So those were 80%. And we can see over here that almost 97% of the patient, so they had a clinical benefit rate. So the disease control was in there in 97% of the patients. So only 3% of the patient, they had either progression of the disease or their response was not evaluable. So this is a kind of thing when you start with a drug and you know that yes, our patient is not going to progress in the first assessment at least. So then you feel very comfortable in using it. So coming to the Flora trial, overall survival. So again, if we look at the second generation and third generation overall survival, so here osimertinib had given the overall survival of 38.6 months, and it was 31.8 months with a comparator EGFR TKI. So this was the first agent which showed overall survival advantage in the EGFR mutated arena. And we can see over here at 36 months, so 54% of the patient who were started on osimertinib, they were still alive as compared to 44% patient in the comparator EGFR TKI. So this thing is very, very important that these comparator EGFR TKI patients, so they were candidate for osimertinib in the subsequent line, and they had received a few of the patients had received osimertinib in the subsequent line. And despite that, the overall survival advantage was there. If we compare it with the second generation TKI, so Lux Lung 7, so it wasn't having any overall survival advantage. The median overall survival with afatinib was 27.9 months. And if we see the Archer 1050 trial, so yes, numerically the overall survival advantage was there, but the statistical design of Archer 1050 was such that it was a hierarchical gatekeeping procedure which was followed for Archer 1050, which meant that the different endpoints have to be used sequentially. So first, the progression-free survival advantage, if it is there, so then only the overall response rate assessment will be done. And if overall response rate assessment is significantly better in dacomitinib, then only overall survival advantage will be seen. So here PFS was statistically significantly better with dacomitinib, but overall response rate, those were comparable between the dacomitinib and gefitinib. So even if the OS parameters they were reported, so it was not formal comparison and formal statistical comparison were not done for the overall survival. So we cannot take this overall survival advantage, which is mentioned in this chart, as a real one because this is not statistically significant. So we can see over here in the Canadian consensus guideline also they had mentioned that the phase 3 Archer study had a numeric improvement in overall survival. So, but the trial had a hierarchical stratified statistical design, and given that it did not meet significance in overall response rate, and a p-value could not be given to OS because of this reason only. Sorry. So, in Flora trial at 3 years, so 28% of the patient, they had not progressed on osimertinib. So again, it was a tremendous improvement. And we can see that almost 1/4 of the patient, they were still continuing with osimertinib at 3 years. So there is always a concern in our mind, those patients who have CNS metastasis or who do not have CNS metastasis, does the drug work equally good in them? So this analysis was performed in FLORA trial, and those patients with known or treated CNS metastasis, they also had similar amount of advantage with osimertinib, which was there without CNS metastasis patient. We can see the hazard ratio in those with brain metastasis was 0.47, and those without brain metastasis was 0.46. So coming to the intracranial progression-free survival, we can see over here the intracranial progression-free survival was not reached in osimertinib arm, and it was 13.9 months in the standard of care arm. So the PFS, CNS PFS was statistically better in osimertinib versus the comparator. So looking at the CNS response across the trials, afatinib, so there were two trials, in fact, three trials, Lakshman 3, 6, and 7. And these trials had included the asymptomatic brain metastasis. And we can see over here, the response rate in Lux-Lung 7 was not reported as far as the CNS responses were concerned. So in Lux-Lung 3, it was 70% versus 20%, and Lux-Lung 6 it was 75 versus 28%. And the median CNS PFS was 8.2 versus 5.4 in the comparator arm. So if we see Archer 1050, so they had not included the brain metastasis, but if we see what was the CNS progression in these patients, so decomitinib was having significantly less CNS progression as compared to the comparator arm. So osimertinib FLORA trial, so they had conducted a full CNS analysis, and what they found was that the overall response rate in the brain, CNS response rate was 66% in the osimertinib arm, and the median CNS PFS was not reached in those patients who had baseline asymptomatic CNS metastasis. So those patients, the median CNS PFS had not reached. So coming to the safety concerns, because this we are discussing day in and day out. So, and this is the plus point of osimertinib, that it has got the best efficacy and the least amount of toxicity. But if we see the specifically the second generation TKIs, both afatinib and decomitinib, so they are highly toxic because they have efficacy on they have the activity on the wild type EGFR also. And particularly if we see the decomitinib, almost 66% of these patients who were started on decomitinib trial, so they had one dose reduction, and almost one third of the patient they had two dose reduction. And the most common toxicity which we often observe with decomitinib, so those were dermatitis, acneiform rashes, and diarrhea. And there were maculopapular rash also. And if we see the osimertinib toxicity, again the toxicity of diarrhea, fatigue, which were very less grade 3 toxicity, which were seen in the osimertinib, almost comparable to the first generation TKI. So these are the grade 3 and 4 toxicities, EGFR TKI toxicity, which were observed with second generation and third generation TKI. So in afatinib, so it was predominantly the skin and mucosal toxicities in form of diarrhea, stomatitis, which were the predominant one. And in FLORA trial, so these skin and mucosal toxicity were less than 2%. So if we see the dose reductions in EGFR TKIs, so in Lux-Lung 7, afatinib required 41.9% patient required dose reductions. In Archer 1050, almost two-thirds of the patient required one dose reduction. And in FLORA trial, only 5% of the patient they had required dose reduction, and which were comparable to the first generation TKI. So this clearly says that the osimertinib is better tolerable as compared to the second generation TKI. In fact, these trial also had a look at the quality of life parameters, And we can see over here that the quality of life parameter was significantly improved in osimertinib as compared to the decomitinib trial. So coming to the sequencing strategy, it is presumed that if we are starting osimertinib in the first line, we are giving the benefit of osimertinib to 100% of the patient. But on the other hand, if we are starting with first or second generation TKI, so if we start 10 patients on the EGFR targeted therapies, so almost 1/4 of the patient, they will die during the first line, or they will not be a candidate for subsequent line therapy. So out of these 75% of the patient who move ahead with the subsequent line therapy, so almost 60 to 76% of these patients, they will have a valid T790M test result. Out of those 60% patient, 50% uh, will be T790M positive. So if we take together, like if we started with 10 patients, only 3 patients, they will be eligible for second line osimertinib. And that amounts to 30% of the patient who were started on first or second generation TKI. So they will receive osimertinib in the subsequent line. And we are giving the benefit of the best drug, osimertinib, in only 30% of the patient. So, and this analysis has come from these trials. So there are vast majority of trial with first or second generation TKIs, and we can see over here that the subsequent treatment has been received in almost 2/3 of the patients only. 1/3 of the patient, they did not have any access to the second line treatment. And these are the real world evidences of T790M after afatinib. So in the Japanese study, only 43% of the patient, they had T790M after afatinib. In Taiwanese study, 48% of the patient, they had rebiopsy after afatinib failure, which showed T790M. And in another Taiwanese study, 32% was the T790M rate, which was observed in at the progression after afatinib. So less than 50% patients who were put on afatinib in the first line, they acquired T790M mutation. So we have seen that whether to go ahead with the first generation TKI, second generation TKI, or third generation TKI. And if we start with first or second generation TKI, so we have certain pros and cons. So the pros are that the cost is going to be less, and sometimes the accessibility to third generation TKI is not there. For that matter, we can start the patient on first or second generation TKI. And there are a lot of cons in that. So only 30% of the patient, they will be receiving subsequent treatment with osimertinib. So we will not be able to know. So which are those patients who will develop T790M in future, so that we can target those patients with the first generation or second generation TKI. And those patients who are not supposed to get T790M, we will go ahead with the osimertinib. So still we do not have that much of information. So sometimes after progression, the tissue or liquid biopsy is not feasible. So because in tissue biopsy, getting a tissue, it becomes sometimes difficult. And in liquid biopsy, sometimes the DNA extraction is not optimized and is not optimal, so that we are not able to perform the NGS on liquid biopsy. So, and osimertinib, it has shown significant survival and benefit in the first line. So these are few of the uncontrollable factors in sequencing. So first is the toxicity to the drugs. Second is occurrence of T790M. Third is the site of progression. Fourth is concurrent morbidity. And the fifth is patient's choice. So we have to take all these factors, and then only we can perform the sequencing of the drug. So coming to the real world studies which showed all these evidences. So this was the flower trial, which was the Italian trial, which was conducted at 9 centers. In total, 126 patients were enrolled in this trial. And we can see over here, as I was saying, that 30% of these patients, they had brain metastasis at baseline, and 50% of these patients were exon 19 deletion. So we can see over here The PFS in this trial was 18.9 months, which was in line with the FLORA trial. So the time to treatment discontinuation was 25.3 months, and the median time to treatment discontinuation in patient with or without symptom at diagnosis. So those who had symptoms, they had progressed earlier, and those patients who were not having symptoms, so they had the median was not reached in those patients. So if we see less than three, more than three metastatic site, less than three metastatic site, it was not reached. In more than three metastatic site, the median PFS was, median TTD was 21.4 months. Sorry. So those patients with or without brain metastasis, if we see the median PFS was not reached in those patients who were having, who were not having brain metastasis, and it was 13.3 months in those with brain metastasis. So median PFS in those without symptom was not reached, and with symptom it was 15.5 months. So osimertinib has shown its efficacy in the real world also. Dr. Manish had alluded on the data of first. I'm very sorry. So if we see the diagnostic pathway, safety data, and conclusion of this FLOWER study, we can see over here in those patients without recurrent disease. So there were a lot of problems. So the median time from biopsy to pathologic report was 7 days. So from pathologic report to EGFR mutation status was taking 8 days. So EGFR mutation status report to osimertinib start was 17 days. So in total, we can see over here, it took around 1 month when the patient came to the physician and was starting the evaluation and receival of the first dose of osimertinib. So it took around 1 month. So in real world, so this sometimes lead to lot of attrition of our patient, and there will be a minority of patient who will never receive osimertinib if we do not improve on these parameters. So the second thing is that among those patients who experience progressive disease and then were evaluated for the same. So then 47.7% patient only underwent a rebiopsy at progression. And in tissue rebiopsy, 66% were the tissue rebiopsy and 29% were the liquid biopsy. And when molecular analysis was performed on these 13 samples, so the druggable resistance mechanism was found out in 7 patients, and they were MET amplification, EGFR amplification, HER2 amplification. So these are the real world data and real world scenario which were observed in this FLOWER study. And we can see over here that the venous thromboembolism was something which was reported in high incidences in the real world study as compared to the phase 3 trial. So venous thromboembolism was reported in almost 10% of the patient. And if we see age wise, performance status wise, comorbidity wise, or tumor load wise, so the venous thromboembolism risk was similar in these patients. Another real world study, which was OC-FACT, it was a study conducted in Japan. It included almost 538 patients, and the results were in concordance with the FLORA trial. The median PFS was 20 months. Median time to treatment failure was 19.1 months. So we can see over here that again pneumonitis was observed in 12.8% of the patient, which was again which was discordant from the FLORA trial. So coming to another real world study, which was Mykonos, it was a multi-center study and it had included almost close to 600 patients. And what they observed was that at the interim analysis, almost 58% of the patient, they remained on first line osimertinib therapy. And if we see the real world time to next treatment or death, so it was 17.9 month in the osimertinib, and real world time to treatment discontinuation was 17%. And on multivariate analysis, so these were related to these factors: smoking status, Charlson comorbidity index, EGFR mutation type, and the number of metastatic site. So after seeing a lot of data, let us see the guidelines also. So in exon 19 deletion or L858R mutation, which are termed as common mutations, so or osimertinib is the preferred category 1 option for these patients. Yes, we do have other strategies which we were discussing initially. Those are the first generation TKI, second generation TKI, TKI Remu combination, TKI Bev combination, TKI chemo combination. So we do have a lot of strategies with that. So this is the ASCO guidelines, which says that stage 4 non-small cell lung cancer, if you get sensitizing EGFR mutation, osimertinib monotherapy is the preferred option. Rest of the strategies, so they have to be used in some patient depending on the logistics parameters. So to summarize, osimertinib is the only EGFR TKI which has demonstrated a clinically and statistically significant improvement in overall survival. The median OS benefit of greater than 3 years set a new benchmark for osimertinib and provides a window of opportunity for patient of stage 4 NSCLC. Flora is the first time an EGFR TKI has translated PFS into an OS benefit. 30% of the patient, they still remain on osimertinib at 3 years. It is the only drug which can be given in the brain metastasis patient and in T790M mutation. It is one of the safest and least toxic drug among all the options. And sequencing probably is not the best strategy, as almost 70% patients, they will never receive the benefit of osimertinib in the second line. So with this, I would like to end my talk. If there are any questions, I think we can take up right now. Thank you.
Thank you, Dr. Praveen, for such a wonderful talk. So I would like to ask you whether you have completely shifted your practice to osimertinib in the first line, or you still have some space for second line drugs or drug like erlotinib plus VEGF inhibitors.
In common mutations per se, I always give the option of, I have always counsel the patient for osimertinib. So because it's almost similar to the breast space where we are giving the option of CDK4/6 inhibitor to all. So we have considered lot of circumstances, only bone metastasis, elderly patient. So because it is such a less toxic drug that you can give the drug to everyone. The only toxicity which we often face is the financial toxicity. So if affordability is there, I think uh, all of the patients should be given the advantage of osimertinib.
Thank you so much, Dr. Praveen. So in the end, I would like to thank all my speakers, Dr. Anuradha, Dr. Priyanshu, Dr. Abhishek, Dr. Praveen. And I would also like to thank all of my colleagues and friends who have joined this session and made this CME a success. Good night to all of you. Thank you so much for your patient hearing.
Good night.
Good night.
Good night.